Okay, thank you very much. I welcome all the participants to this second webinar of Comprehensive Neuroanatomy Educational Program, Module 3. So, as a neurosurgeon and as an expert in neurosciences or participants in neurosciences, it is very imperative to know the anatomy, especially the neuroanatomy. So, without any further uh, delay, I would request our first speaker, Dr. Yousuf Shaikh, who's working as Assistant Professor of Neurosurgery at Liaquat National Hospital, Karachi, Pakistan, to talk on gross and microscopic anatomy of the cerebellum. Yes, please, Dr. Yousuf Shaikh.
Thank you, Dr. Usman. It's always an honor to present on this forum. And we'll be talking about the anatomy of the cerebellum with some surgical aspects to it as well. And I was informed that there'll be resident students as well. So I'll try to go slow. And I think it's better that rather than finishing it off and not getting anything, it's better that we go slow and get something out of this session so that we can remember. So to begin with, we know that the cerebellum is situated in the posterior fossa, and for descriptive terminology or description, we divide it into three surfaces. The first is the first cortical surface, that is the tentorial surface. It faces the undersurface of the tentorium, and this is generally the part that we retract when we're doing a supracerebellar approach. Then the second surface is the suboccipital surface that is situated posterior inferiorly. And this is situated between the sigmoid sinuses and below the lateral sinuses. And this is one of the most common sites for approach for suboccipital craniotomies and approaches to fourth ventricles. The third surface is the petrosal surface, which is situated anteriorly. It faces the petrous part of the bone, and this is the general area that we access during approach to CP angle tumors that we frequently do, such as acoustic neuromas or dermoids, epidermoids. Now, each of these surfaces has a bilateral cerebellar hemisphere and a central midline structure, which is known as the vermis. And today what we are going to do is that we'll discuss each surface one by one, and then we'll go on to the deeper dissection on these surfaces so that we can understand the other structures attributed or beneath the surface anatomy, including all fissures and various parts of it. So, first of all, the tentorial surface. Now, as I said that I've mentioned that this is the tentorial surface which faces the undersurface of the tentorium. Now, this part, which is the anterior-medial part, this part that is the anterior-medial part of the tentorial surface is referred to as the apex. This is the part of the vermis which is the highest point of the cerebellum. So if you look at it in the sagittal section, it will be the highest part of the cerebellum. So we refer to as the apex. Now, on this surface, you can appreciate that the transition from cerebellar hemisphere to the vermis and then the cerebellar hemisphere is relatively smooth. There are fissures which go on in a continuous fashion, and there is a gradual transition. So you can't actually demarcate that on the tentorial surface, the vermis is separate or the hemisphere is separate, because on this surface, there is no demarcating fissure between the vermis and the cerebellar hemisphere. However, they do have certain notches. This V-shaped structure is the anterior cerebellar notch. You all can appreciate. And posteriorly, we have this depression known as the posterior cerebellar notch. You can see that the anterior cerebellar notch is housing or facing the brainstem and is an important structure forming a posterior wall of the cerebromedullary fissure, cerebellomedullary fissure. Whereas the posterior cerebellar incisura, this depression, contains predominantly the falx cerebellum. So the anterior cerebellar incisura houses the brainstem, predominantly the midbrain, and the posterior cerebellar incisura houses the falx cerebellum. Now we go on to the borders. This is the anterior and anterolateral medial border of the tentorial surface that separates it from the petrosal surface. So this border is divided into two parts. This part is known as the anteromedial border, and this laterally, or this part laterally, is known as the anterolateral border. The anteromedial border, as I mentioned, is facing the midbrain, whereas the anterolateral border, this part, it tends to face the superior petrosal sinus. And the part where the anterolateral border and anteromedial border meet, this angle is known as the anterior angle. The clinical and surgical importance of this anterior angle is that this area is just above the origin of the posterior root of trigeminal nerve. So this is the anteromedial border, and this is the anterolateral border. And its union is known as the anterior angle, which is just above the origin of the posterior root of fifth cranial nerve. Similarly, it has a posterior border. This is a posterior border. And again, Croton says that we have divided into two parts, the medial part and the lateral part, this lateral part. The lateral part runs parallel to the lateral sinus, and the medial part, as you can see here, faces the posterior cerebellar incisure. And just like the anteromedial lateral border, the posterolateral and posterior-medial border meet here. This angle, this is known as the lateral angle, and lateral angle is the site where the lateral sinus, sigmoid sinus, and superior petrosal sinus will meet. So both of these angles have surgical importance because of the origin of the structures. Over here, the fifth cranial nerve rises, and over here, it is the union of the venous sinuses. Now, moving on to the hemispheric surface, you can see that on the hemisphere, there are various structures. These include the most important quadrangular lobe. Then beneath it, we have simple lobule. And then beneath that, we have the superior semilunar lobule. Similarly, the vermis has three parts: culmen, declive, and folium. So Croton says that each vermis, because as I mentioned, the hemisphere and the vermis are in more or less continuity with each other on the tentorial surface, the vermian and its representative hemispheric part from anterior to posterior are the culmen and quadrangular lobule, declive and simple lobule, folium and superior semilunar. Moving on to the fissures, the tentorial surface has a primary fissure known as the tentorial fissure. You can appreciate that this is the tentorial fissure, which is roughly dividing it into anterior tentorial surface and posterior tentorial surface. The anterior tentorial surface is just made up of quadrangular lobule, whereas the posterior tentorial surface is further subdivided by a postclaval fissure into simple lobule anteriorly and superior semilunar lobule posteriorly. Then, in addition to these major dividing fissures, you have these smaller fissures, smaller ones, which then from the quadrangular surface turn anteriorly and inferiorly onto the petrosal surface. So some of these fissures are continuous onto the adjacent surface as well. So this is about the tentorial surface. We'll be digging deeper in the later stages, but first we'll cover the surface anatomy of all surfaces. So this is all the text that is written, but I tried to explain it on the pictures, and I'll continue to explain on the pictures and read minimal text as possible. Suboccipital surface. Now, suboccipital surface is probably relatively, it's not complex, but it is relatively more complex than the other surfaces, and it is probably the most important to understand. This is the reason because most of our approaches to the fourth ventricle or tumor is directed through the suboccipital surface. And the suboccipital surface, as I mentioned, is the one between the sigmoid sinuses and below the lateral sinuses. So to begin with, the suboccipital surface has this vertical depression in the midline. You can appreciate this is the cerebellum, but as you can appreciate this angle, so this is a vertical depression. And as I mentioned, this is the inferior continuation of posterior cerebellar incisura. So this is posterior cerebellar incisura. And I have stated previously that it contains the falx cerebelli. Now, the dural folds then go on to the vermis as well. So this is the vermis. And vermis, unlike the tentorial surface, is separated from the cerebellar hemisphere. So the posterior cerebellar incisura over here has lateral walls, which are made up of cerebellar hemispheres. And vermis over here is separated from the cerebellar hemispheres by these two parallel fissures, which are known as vermio-hemispheric fissures. Okay, there were no demarcating fissures on the tentorial surface, but on the suboccipital surface there are visible fissures, these two on each side. So now, if you look at the vermis over here, the vermis has four parts: folium, tuber, pyramid, and uvula. And this part of the vermis is said to be diamond in shape. So you all can see my mouse movements, right? Okay, so this is diamond shape. So Roton says that we have divided this diamond into upper half and this lower half. Because this upper half resembles the shape of a pyramid, it is known as pyramid. And this is also the widest portion of the vermis on the suboccipital surface. The vermis is widest over here. The lower half is formed by the uvula, and the reason it is called uvula is just because it resembles the uvula of the oropharynx. It tends to hang in between the tonsils. And in this case, they are referred to as tonsils as well. So this is the uvula. Just above the pyramid is the folium and tuber. Okay, so I've mentioned this is diamond in shape, and then we move on to the cerebellar hemispheres. If you look at the vermis as well, there is a part of vermis which you cannot see, that is known as the nodule. Now, nodule is located deeper to the uvula. So unless we remove the uvula, we will not see the nodule. But in the subsequent slides, when we will dig deeper into the dissection, I will show you the nodule and what is its important clinical significance. So, inferiorly, if we continue to go down, then this posterior cerebellar incisura opens into vallicula cerebelli, which drains into the fourth ventricle via foramen of Magenti. So similarly, each part of the vermis has a corresponding representative hemispheric structure. So the folium correlates to superior semilunar lobule, tuber correlates to inferior semilunar lobule, pyramid correlates to biventricular lobule, and uvula correlates to the tonsillar portion. Now, just like the tentorial surface, the suboccipital surface also has a major fissure, which is known as suboccipital fissure. This is just one fissure, but yet again, we have divided into two parts: the hemispheric part and the vermian part. The vermian part is separating the tuber and pyramid, whereas the hemispheric part is separating the inferior semilunar lobule from the biventricular lobule. And then there is also another fissure known as petrosal fissure. Now, this is primarily a fissure of the petrosal surface. It actually turns on the suboccipital surface and it creates the superior and inferior semilunar lobules, this petrosal fissure. Superior and inferior semilunar lobules. Now, the most important structure on this surface is predominantly the tonsils. These are the tonsils. Now, these tonsils are sort of overhanging or blocking the entry of the fourth ventricle. And they are roughly ovoid in shape, or you can say they are bean shaped like that. And they are attached to the cerebellum by means of a peduncle. So these are the tonsils. They are attached to the cerebral hemisphere by means of a peduncle. Even though on the lateral surface it seems continuous, but it is said that it is separated from biventricular lobule by means of a fissure. They have not yet named the fissure, but there is a fissure or a narrow cleft. So the inferior surface of the tonsil and the posterior surface. The inferior pole and posterior surface faces the cisterna magna over here. The anterior surface of the tonsil, that is on the rostral aspect, it faces the medulla to form the cerebellomedullary fissure. The medial surface are in proximity to each other, that is the medial surface of the tonsils are projecting onto each other towards the vallicula leading to the fourth ventricle. And the ventral aspect, that is the rostral aspect, it has three very important structures. Okay, we'll be digging deeper, so I'll show you the slides configurations later. But understanding that the rostral, ventral to the superior pole of tonsil are the three most important structures: the inferior medullary vellum, tila choroidi, and the nodule, which I mentioned is the part of the vermis located just beneath the uvula. And these three structures form the lower half of the roof of the fourth ventricle. And these are the 4-5 structures over whom the entire approach to the fourth ventricle and suboccipital craniotomies are laid out. So this is all what I have described. Tonsils, I have described their surfaces: the medial surface, the lateral surface, inferior pole, and most importantly, the ventral aspect. The ventral aspect of superior pole of each tonsils faces three structures: tila choroidi, inferior medullary vellum, and nodule, forming the roof of the fourth ventricle. This is the important aspect. Finally, we move on to the petrosal surface. Now we know that petrosal surface is the anterior most surface. So we have rotated the brainstem. So now we are looking at it anteriorly. So it faces the brainstem, petrous, and fourth ventricle. It also has a deep anterior depression in which this brainstem is located. So the posterior surface has a vertical depression that was posterior cerebellar incisura. This is anterior cerebellar incisura, which is containing the brainstem, that is the midbrain, pons, and medulla oblongata. Now, unlike the other surfaces, the cerebellar hemispheres over here are not connected to each other directly. This is because the fourth ventricle is intersposed here in the deeper midline. So the cerebellar hemispheres are not connected to each other over here. And it has a very major fissure that is known as petrosal fissure, dividing the superior and inferior semilunar lobules. And this petrosal fissure has an anterior limb and a posterior limb. That is a superior part of the petrosal fissure and inferior part of the petrosal fissure, and this is known as the angle. That is the formation. Now these fissures are important because almost all the cranial nerves are originating from these fissures. So we'll be coming to that as well. And each hemisphere has the wings of the central lobule plus the semilunar and inferior semilunar lobules. Now, what we'll do is we'll go into the deeper dissection of the surfaces one by one. We first talked about the tentorial surface. So, and we said that this is the anterior medial border and this is the anterior cerebellar incisura housing the brainstem. So the upper part of the tentorial surface surrounds the posterior half of the midbrain and forms the cerebellomesencephalic fissure. This is the cerebellomesencephalic fissure, and it contains the brainstem, which I've said. We have removed some part of the brain over here, so you can appreciate that the medial border is formed by the culmen, whereas the lateral border is formed by the quadrangular lobule. Now, these are the borders of the posterior wall of cerebellomesencephalic fissure. Okay, so this is a cerebellomesencephalic fissure, and its posterior lip is bordered by the quadrangular lobule laterally and medially by the culmen. And just rostral or anterior to it over here is the quadrigeminal cistern that extends from the pineal area down to the cerebellomesencephalic fissure. Okay. Next picture. This is the same picture. We have just rotated the angle. Okay. So let me just, this is looking at it from the midline, and now we have rotated it. Now we have rotated it slightly. And what we have done is that this was the anterior cerebellar incisura and this was the culmen. So what we have done is we have cut half of the culmen and removed the quadrangular lobule. So you can see that this is the central lobule. Because we are dissecting deeper onto the from the tentorial surface, so we are heading more towards the petrosal surface. Okay, so this is the central lobule, and these are the wings of the central lobule. And again, these are the components forming the posterior wall of the cerebellomesencephalic fissure as you go laterally. Now we will remove this as well. We have removed the central lobule and its lateral wings, the midline lingula, the superior medullary velum. And over here, we have also removed some part of the superior peduncle. So what you see over here in the midline is the nodule. And as I mentioned, nodule is the deepest part of the vermis that is located deeper. So we have to remove part of structures to appreciate the nodule. Over here, we have the inferior medullary velum. This part is known as the tila choroidea, and these structures together are forming the part of the fourth ventricle. So you can appreciate the nodule, the inferior medullary velum, and this part is known as the tila choroidea. Now we have removed some part of over here in this diagram, the middle cerebral peduncle as well. So you can see that how the choroid plexus are entering through the lateral recess into the CP angle just around the 7th and 8th cranial nerve over here. And now we are going to rotate it yet again, the same picture. This is the nodule. This is the inferior medullary velum. This is the tila choroidea. This is the choroid plexus that is running along the lateral wall along with the 7th and 8th cranial nerve. And this inferior medullary velum, which is arising from the surface of the nodule, extends laterally underneath the middle peduncle to the flocculus, forming the flocculonodular lobe of cerebellum, this structure. Okay? This is the flocculonodular lobe. Now, moving on to the occipital surface. I have already described the surface anatomy, and the important structure over here is this cerebellomedullary fissure that is just beneath the tonsils. Over here is the cerebellomedullary fissure between the cerebellum and medulla along the inferior half of the ventricular roof. And this over here is the vallicula, which is between the tonsils and communicates with the fourth ventricle through foramen of Magendie. This is the folium, tuber, pyramid, uvula. These are the tonsils. This is the foramen of Magendie from the vallicula to the fourth ventricle. And deeper to uvula, what we will find? Nodule. So what we have done is that this is the normal anatomy that we have seen. We have retracted the tonsil. I think everyone can appreciate that this is the retractor. We have retracted the tonsil. So the right tonsil has been retracted to expose the lower part of the roof of the fourth ventricle. And what you can see, the same structures, that is tila choroidea, inferior medullary velum. Inferior medullary velum, tila choroidea. And this is the junction between the two. And this is the reason that what we do, the tilovelar approach, is because it is the junction of the inferior medullary velum and tila choroidea. So it is known as tilovelar approach. So nodule over here is yet again hidden by the tonsils. Once I will remove the tonsil, we will appreciate the nodule over here in the midline. The choroid plexus you can appreciate over here arising from the inner surface of the tila and extends through the foramen of Luschka behind the glossopharyngeal and vagus nerves. This over here, choroid plexus, it enters via the foramen of Luschka into the towards the fourth ventricle. The inferior medullary velum arises on the surface of nodule and it drapes along the superior pole of the tonsil. So this tonsil has been retracted. In the next picture, we will retract both tonsils. So now it becomes bilaterally symmetrical. Yet again, the uvula and both the tonsils. This tonsil has been retracted, and you can very clearly appreciate the symmetrical tilovelar junction. This is the inferior medullary velum, this is the tila choroidea, and this is the tilovelar junction. And this rhomboid lip. Now it is like a sheet of neural tissue which is attached to the lateral margin of the ventricular floor, and it is posterior to the glossopharyngeal and vagus nerves and joins the tila choroidea to form an outpouching over here. So I did not understand this part clearly for some reason, but this is what is most important, tilovelar junction. Now what we will do is we will remove the right half of the tila, and now that we have removed the tila choroidea, we have exposed the lateral recess and the fourth ventricle. The inferior medullary velum over here, you can appreciate it extends laterally to form the peduncle over here, and peduncle to the flocculus, which blends into the flocculus at the outer margin of the lateral recess. Inferior medullary velum, peduncle, and then the flocculus. And this is the entry to the fourth ventricle. We have removed both the tila choroidea in this diagram, and you can clearly appreciate the lateral walls of the fourth ventricle, which are formed by superior cerebellar peduncles. And this is the opening to the fourth ventricle, which will be used for accessing or removing tumors via tilovelar junction. So this was about the deeper dissection on the suboccipital surface. Now, finally, the deeper dissection of petrosal surface. Now, the important things that we're going to talk about is the petrosal fissure. The petrosal fissure is a V-shaped fissure, and it has a anterior limb, or which is the superior limb, or the inferior limb. This inferior limb and this superior limb meets over here, which is known as the apex, and they form a petrosal fissure combined. Cranial nerves 5 through 11 arise from the margins of this cerebellopontine fissure. And we all know this is the basilar sulcus, which contains the basilar artery, and the flocculus and choroid plexus extend laterally by the foramen of Magendie above the lower limb of this fissure. Again, magnified view of this surface, that is the petrosal surface, which showing the petrosal fissure. This is the petrosal fissure. The apex of the cerebellopontine fissure with its superior limb and inferior limb. The abducens nerve, that is the sixth nerve, here it is. It arises in the medial part of the pontomedullary sulcus. Then we have the seventh and eighth cranial nerve, these ones. which arise just rostral to the foramen of Leschka and lateral to the pontomedullary sulcus. So medial to the pontomedullary sulcus was 6th, 7 and 8 are lateral to the pontomedullary sulcus because this is the pontomedullary sulcus we can all appreciate. And hypoglossal nerve arises anterior to the glossopharyngeal vagus and accessory nerve. This is the 12th cranial nerve which is anterior to the glossopharyngeal vagus and other cranial nerve. And choroid plexus, it is often used as a surgical landmark as well, which travels along with the glossopharyngeal and vagus through the foramen of Leschka. This is generally what we see in tumors such as ependymoma because they tend to arise from the floor of the fourth ventricle, predominantly involving the foramen of Leschka as well. Yet again, a very magnified view and clearer picture of the same area, showing the apex of the cerebellomedullary cerebellopontine fissure. Then we have the glossopharyngeal nerve, vagus and accessory nerves arising from the inferior limb of the cerebellopontine fissure. So we have this 10th cranial nerve, that is the vagus nerve. The 7th and 8th nerve, these two are arising in the mid portion of the fissure near the trigeminal nerve, and the hypoglossal nerve arise in front of the over here. The hypoglossal nerves arises over here in front of the olives. So that was most of it about the surface anatomy of the cerebellum. And if we go deeper, we have identified the various structures and the various fissures and the surgical anatomy. But yet again, the most important structure or the most important surface is the suboccipital surface, because generally the supracerebellar approach is restricted to tumors of the pineal area, which are not that common. And yet again, CP angle tumors, you do well, which is easy to approach, but approaches to the fourth ventricle are most important. So again, this is just a picture of the roton showing that how we are retracting in an operative view or during a surgery, how you will retract the cerebellar tonsils to expose the tila. This is the uvula. And then you retract the tonsils to expose the telovelar junction, inframedullary velum, and then you open that to expose the tumor. And this is the telochoroidea. So that is probably it from the presentation. And I hope it was not very difficult, or on the contrary, not very easy as well. So I hope it was beneficial for all of us. Any questions regarding the anatomy?
Yeah, thank you very much, Dr. Yousuf. I must say, very excellent talk on the gross and microscopic anatomy. There is a question in the chat box from Hafsa Mahmood, and that is nodule is behind folium or decline?
Nodule is just behind the uvula. Behind the uvula. So you have to remove the uvula to appreciate the nodule.
Okay, thank you. Anybody want to ask something? Any questions? Okay, if there is any question, you can type in the chat box. Maybe if the time allow, we will discuss at the end of the second talk. Thank you once again, Dr. Yousuf.
Thank you,
Now,
Professor.
I would like to,
Riaz,
yeah. I think Professor Riaz Ahmad Raja, the President of Pakistan Society of Neurosurgeons, is here. Sir, if you want to
Assalamu alaikum,
comment
and
also.
thank you so much. Hi, everyone. And it was really a nice talk from Dr. Yousuf. And the topic was very complex. Always, a posterior fossa is a very complex topic, and having a lot of the things and to learn in the posterior fossa, CP angle, the midline tumor, the supracerebellar, craniovertebral. So I think he has fulfilled and captured all the topics, and gave a very nice talk on the topic of the cerebellum. So I would like that more emphasis should be given to the surgical oriented, particularly the tumors and the AVMs and what are the other neurosurgical procedures, so that our juniors can learn more from the more surgically oriented neuroanatomy. So thank you so much, Dr. Yousuf, and thank you so much, Ahmed, uh, uh, Ahmed Saleh. So I think over to you, Dr. Osman, for the next talk.